Right, hi everyone, and welcome to this NHS Providers webinar, which aims to give parliamentarians an update on the current situation facing NHS trusts and help answer any questions you may have about coronavirus. NHS Providers is the membership organisation for all NHS hospital, mental health, community and ambulance services that treat patients and service users in the NHS. Before I hand over to Chris and Saffron, just a little bit of housekeeping. The webinar is being recorded and will be shared on our website after the event, and we can send you a link to that as well. There'll be an opportunity to ask questions, so please use the chat box that you will see at the bottom of your screen to ask your question. I will then call on you and unmute your microphone for you to ask your question. We ask that you keep questions brief to allow as many as possible an opportunity to speak. If we don't get to your question, we'll make sure the chat is saved and come back to you with an answer after the webinar. Thank you. So over to Chris.
Thank you, Kerry. That's very kind of you. Can I just thank all of you for joining? I know it's a very busy time, and we've been very pleased by how many of you have indicated that you wanted to join. So what we thought we'd do is deliberately, we wouldn't talk very much. We'd effectively give you the opportunity to ask us questions. So if I just give you 5 minutes on where we think we've got to so far, and I'll then hand over to Saffron, who's the Deputy Chief Exec, who can talk to you about what we think the challenges coming up are. So our kind of sense is it's always good to sort of step back. You know, it's been, what, a couple of months, 2-3 months now. First, it was formally declared an incident at the end of January. Our kind of sense is that from an NHS perspective, over that first initial peak, we think the NHS did a really pretty good job of effectively completely shifting its shape to create 33,000 extra beds or new beds to treat coronavirus patients. And that was done in a number of different ways. I think we all of us in the NHS acknowledge that that has understandably had an impact in terms of care for other patients. But and to be honest, we're slightly nervous about the fact that the debate might start turning round to, well, hold on a second, you created far too much extra capacity, and actually you, as a result, have created more patient harm than might otherwise have been the case. But I just take you back to the beginning of February, when it was really very clear that there was a need to avoid the overwhelm that we'd seen in northern Italy, and that was very clearly set as the NHS's very clear priority. So if you look, there's a briefing that we did about 4 or 5 weeks ago called Confronting Coronavirus, which we'd recommend to you if you haven't read it, which just set out how all the different sectors of the NHS, community, mental health, ambulance and acute hospital trusts, we think did a very, very good job of creating that extra capacity. As it turned out, all of that capacity wasn't needed. And now that we've gotten past that first peak, it seems to us that we're now about to head into the much more difficult task of really working out how do we run coronavirus services, treating coronavirus patients alongside restarting ordinary NHS services. So at that point, given that I'm now looking forward, I'll hand over to Saffron, and then let's get into Q&A and dialogue.
Thanks, Chris. So yeah, Chris has talked about this need to manage surge, and it's absolutely critical that the NHS frontline thinks really carefully about how we manage that surge alongside reintroducing care to meet that unmet demand and to meet new demand that has built up over the last 2.5 months. And to do that in a way that is, of course, socially distanced in line with what we need to do with the coronavirus environment. So in a bit more detail, what that means is actually looking at how we clear some of the backlog of elective surgery and elective treatment, how we think about the rehabilitation needs of those who were discharged early from hospital and who may have developed needs for greater treatment over that time. Think about how we meet the new demand and pent-up demand in mental health, and we think this is coming from a number of places, both in terms of economic and social challenges, but also in terms of loss of life challenges, but then also people who have not come forward for treatment or been referred during the coronavirus period, and we're really worried about that, along with other pent-up demand, which means that people with a physical health condition may be facing more complex treatments because of the delays that they have encountered. We also need to think really carefully about supporting social care. We've always said that if you cut social care, the NHS bleeds and it goes the other way, and we need to think about how we support social care going forward. And as the NHS frontline, we also need to think about how we support testing. So there's a big task ahead of us, and there are also some significant constraints as well. So, how do we actually accurately forecast what the demand is going to be, both COVID demand and non-COVID demand? How, if we're going to treat people safely, do we make sure we've got a sustainable supply of PPE? And we all know the stories about PPE to date. How do we make sure that we keep our staff and patients safe alongside PPE with a really effective, regular, fast turnaround testing regime? And how do we manage those capacity constraints that come from an overstretched community mental health and social care system when we are all needing to operate in a new environment which incorporates social distancing, which is very, very challenging for a number of services, particularly those who have difficult estates to deal with. But last and not least, really, we also need to think about our workforce going forward, because we came out of winter with a very tired workforce. We go into the coronavirus with a very tired workforce. They are now extremely tired. So we need to think really carefully about how our workforce is managed. So what the sector needs really is the best possible estimate of future demand. And I think that's quite a sophisticated task ahead of the whole sector, health and care. Really effective, sustainable supplies of PPE and a resolution to the issues around testing that we've seen. Really good prioritisation of how we start to clear that backlog across all of the services we provide. Thinking about how we use the workforce in new and different ways, thinking about all of those volunteers who've come on board and also people who've returned to the profession at our request. But really what we need is an honest conversation about how much we can do and how quickly, given the constraints we are facing, but the real desire to get back to work in this new environment. Thank you.
Thank you, Saffron. We'll start with a question from Lord Hunt.
Hello, can you hear me?
Yes.
Yes, we can.
Okay, great. So I had a couple of questions. One was to ask you about the reports that some medics who've been expressing some concerns about safety, PPE testing issues, have had CEOs come down on them hard. I just wondered if you could comment on that. And what is if it is so, why are chief execs so concerned about their medics talking openly? The second thing is really, actually, Saffron answered it to an extent. I'm just wondering what's happened to the NHS long-term plan. I assume it may need recalibration in view of the pressure to catch up on so many of the procedures that have had to be postponed. And I just wondered if there was work being undertaken within the NHS, thinking about how we might go forward over the next, say, 3 to 5 years. Much.
So thanks, Phil, and good to hear you. So I'll do the PPE concerns bit, and then if Saffron wants to pick up the long-term plan. So I think the PPE concerns one is a slightly difficult one in terms of two or three things to start with. First of all, we obviously can't vouch for every single individual circumstance, so it's difficult for us to be definitive. The thing that we find interesting is that whenever one of these kind of crops up, we do tend to talk to the trust concern. And what consistently comes back is there are definitely a very small number of staff who, for very understandable reasons, because all staff, to be frank, are concerned and worried about their own personal safety. But there are definitely a very small number of staff who believe that the guidelines that have been agreed nationally are evidence-based, are actually in line with World Health Organization guidelines. that they believe that the guidelines are simply insufficient, and they are very insistent that they want a higher level of protection of PPE. And what happens is there's quite a difficult conversation that needs to go on between those individuals and their line managers, because the line manager, and potentially it gets escalated, is effectively trying to ensure that the right PPE is used in line with the guidelines, particularly when they've got the rest of the staff who are following those guidelines. So we think that some of these incidents, and because we track them back, are effectively what then happens is, and just to be clear about what happens if there is a disagreement between individual members of staff who wants to go further than the guidelines, and what the management then do, what they tend to do is say, well, look, I'm sorry, it's our job to enforce the guidelines, but actually if you don't want to work in that environment and you're insistent that you won't, then let's find alternative duties for you so that effectively you aren't quite put in a position that you're uncomfortable with. But we know that on some of these incidents, what's then happens is that the members of staff who feel very strongly about it, and interestingly quite a few of them tend to be agency staff as opposed to permanent members of staff, they then effectively feel that it's their duty to go to the local newspapers or to effectively raise this as an issue of concern. And they effectively say that because management hasn't listened to them, their concerns have not been taken account of. So as I said, we've tracked back on at least 3 or 4 of these kind of cases that have been relatively high profile. And interestingly, in all 4 cases, that is what has happened. I can't say definitely that there hasn't been issues of where, to be frank, chief executives have been unduly exercising pressure. But to be frank, we would be surprised about that, because I think, as you know, and you share the trust yourself, what's happened over the last kind of, particularly since mid-staffs, is there has been a very strong emphasis on building that whistleblowing culture and on building the freedom to speak up guardians. But I just thought that that's obviously not something that we've particularly stressed in the media, because it's clearly quite a difficult issue. But we just found it was interesting that when we tracked back, that is what had occurred. Saffron, do you want to pick up the long-term plan question?
Yeah, so I think I feel it's a really interesting question on the long-term plan. I think that where we're at the moment is people are starting to kind of lift their eyes away from coronavirus and managing that really big initial impact to think really carefully about how we plan over the coming period. And I think that it's kind of, as I understand it from the conversations I've been party to, planning over different chunks of time. So there's an immediate chunk of time, the next kind of 6 weeks or so, then the next 3 months, then the next 6 months, then the next 9 months, to really get the NHS somewhere close to being back on track. So that's the first thing to say, which is that there's very much the planning to get us out of emergency coronavirus operating environment. Also bearing in mind that obviously the likelihood of a second surge or a second peak of cases is definitely out there. I think in terms of where the long-term plan actually sits, no one has said that it no longer exists. No one has said that we aren't working to the long-term plan. My view is that all of the principles and elements that underpin the long-term plan, the vision for the NHS over the coming period, still hold, but how we operate, I think, will change considerably. So whatever happens, whether we keep the principles of the long-term plan and perhaps steer the car, as it were, in a different direction, remains to be seen. So I don't think, to be frank, it has been ditched, but I think lots of people are thinking very carefully about how we go forward in a totally new operating environment. But clearly there are elements of work that have come out of the long-term plan and other developments, such as STPs and ICSs, which are still in operation, still being used to plan and deliver. But I think also with those, we might see a slightly altered emphasis as we go forward. So I haven't heard personally that the long-term plan will no longer exist, but it must be up for conversation about how it gets forward, how we go forward.
Thank you. I can see we've got a question from Baroness Jolly. Baroness Jolly?
I'm quite interested in the sort of contact and relationship over the last few months you've had with the Department of Health and Social Care. And in a sense, that could be relatively straightforward in that it's at least with one body. But well, how do you manage contact with social care if ever you want to have a sort of a strategic conversation with somebody about social care rather than with all the various providers?
So well, that's a good question. I think one of the issues about the social care sector is that there is a degree of fragmentation. When we at our national representative organisation level want to have a conversation, we tend to talk to Care England, who represent the providers, and then we also tend to talk to a combination of the Local Government Association and the Association of Directors of Adult Social Services, who are effectively the commissioners. But I do think that one of the issues here has been the degree of fragmentation in the social care sector. Certainly, I mean, you probably will have seen, and there's going to be more, I think, on this over the next 48 hours, about this debate about the degree to which the NHS is responsible for what's happened in social care, where clearly there has been a regressively high level of mortality. And I think certainly when we've deliberately had quite a long conversation with with trusts about how they have been implementing discharge policy. Our sense is that actually at a local level there is usually a pretty good quality of relationship between trusts and care homes, because to be frank, they're talking to each other most of the time in terms of doing discharges backwards and forwards. And the bit that I think our trusts, and again, if you haven't read it, we produced a briefing I think earlier on this week about discharges from the NHS into the social care sector. The bit that our members are really, really upset about is the accusation that effectively they've been systematically and knowingly, deliberately discharging COVID and suspected COVID patients into the care sector, when in fact they've been bending over backwards because they know how fragile the care sector is, because they have to deal with it literally day in, day out. They've been working really hard to try and ensure that the social care sector is well supported. And certainly there are obvious places where the relationship is better than others. And we see stories of, care homes saying they've been pressured by trusts. But our kind of sense, as we've talked to trusts, as it has always been over the last, 2 or 3 years, is that actually on the ground, particularly clinician to care home manager, actually there is a good quality of relationship between the NHS trusts and social care, with some, somewhat understandable inevitable tensions.
Can I just come in on that point as well? I think that there's also, you raise a really good point about how do we talk collectively to social care. I think that in terms of the structure of government around social care, that's also quite challenging, because we have a lot of social care policy that sits within the Department of Health and Social Care. Then we've got funding that broadly sits with local government. And so I think that division, whether it's purposeful or not, does create all sorts of issues when we're trying to reach common voice and be really influential in order to get the right outcome for social care. The fact that the money sits in one place and the policy and direction sits in another place, obviously all held in balance by the Treasury, does create quite a complex environment. And I think that's also where some of the challenges can come in trying to effect some real change.
Thank you. We've got a question from Richard on behalf of Marcus Longy MP.
Yes. Recently we've been contacted by patients in Dudley saying that the new information being given by the NHS that they're having to isolate for 2 weeks before operations, and they're worried now that they're having to go back on the sick. Are the NHS going to be providing sick notes to accommodate all this regarding isolating before operations?
I must admit, I'm not fully up to speed with exactly how the sick note process is kind of working at the moment. But if in terms of what you put on the chat, I think there were 2 elements to the question. One is, why is this happening? And the second is, can the NHS provide the sick note? In terms of why this is happening, the reason it's happening is that we're very, very clear that given the risk that this virus is, and this is the phrase of the moment, nosocomial, in other words, effectively, it tends to have higher prevalence in healthcare health and care settings, there's a real priority on ensuring that anybody who comes into a hospital or a healthcare setting for a treatment, an ordinary treatment, is coronavirus free. And to be frank, the same applies to the staff who are treating them. And so what we've done in the NHS is we've developed not a new set, but a renewed emphasis on the importance of infection control. And as part of restarting NHS services, there's been a really clear view that we shouldn't be enabling patients to come into hospital for a treatment or an operation unless we can be sure they're coronavirus free. Two ways of doing that. One is if you self-isolate for 14 days, that's a very good way of ensuring. The second way is to do a test a couple of days beforehand. And I thought Saffron was customarily excellent when she pointed out that this is one of the real problems we've got at the moment. There is simply not the testing capacity in order to ensure that every single person who's meant to be coming into a hospital for an ordinary treatment, but also the staff who are due to be treated, there is simply not enough testing capacity to ensure that that can be done consistently and reliably with a sufficiently fast turnaround time. And just to delve in even just a layer lower, clearly, if you're a member of a patient coming into the NHS, you probably want the test done at home. So we need arrangements to ensure that there are sufficient home tests that can be turned around quick enough. And again, there's simply nowhere near enough capacity or the right arrangements to do that. So this is why we're saying very clearly there are certain barriers and constraints that need to be overcome in order for the NHS to restart. And one of those is we've got to get the testing right. My assumption would be that given that the NHS is requiring individuals to effectively self-isolate for 14 days before they can come into hospital, I'd be very surprised if there wasn't a quick and easy way to obtain a sick note saying this is why the individual is off work. Saffron, have you got any light to?
I don't have any official light to shed on it, but my understanding from the current situation is that if you're self-isolating, you don't need a sick note because the system would be completely overwhelmed by people. GPs would not be able to issue that many sick notes for people self-isolating. So the process has run whereby people are self-isolating basically on the basis of trust. And I think that I imagine that either the sick note process will either continue on that basis that self-isolation does not require a sick note, or that the sick note that you would ordinarily be issued with were you going into hospital for an operation would simply be extended to include the self-isolation period. But that isn't gospel, so that's something we can follow up on and get back to you.
Thank you. We've now got a question from Baroness Barker.
I think we need Liz to unmute.
Hi, my question is, are hospitals going to be able to cooperate regionally to optimize the use of their resources to make up the non-COVID backlog?
Well, the answer is yes, they will be kind of cooperating. And Saffron, you might want to pick this up as well. They will be kind of cooperating to optimize the use of resources. It does slightly depend upon how developed the regional cooperation is. I think, as you may know, NHS England and Improvement set up new regional operations with much greater authority and delegated control about a year and a half ago. And they're still on a bit of a journey to kind of get there in terms of the region working fully functioning. But yes, people will, as they traditionally do, I think, kind of cooperate across the regions to make it work. The bit that I just, because I know a lot of you are really concerned, quite rightly, often about single conditions. The bit I just want to really stress, and I just want to give you a statistic that I picked up this morning, is we just need to recognise about how complicated this is going to be to get services restarted. So I understand from the figure I picked up this morning is that the German system is allocating 25% of its critical care capacity to a surge capacity to treat a possible second wave. So if you're allocating that amount of your capacity towards a to protect surge capacity. And then you're having to divide your hospital. Though if you've got 2 or 3 hospitals, like for example, Phil Hunt's old trust, you can actually have one hospital hot, one hospital cold. But actually, if you're going to divide the hospital into, a COVID zone and a COVID-free zone, and to be frank, an amber zone where you're waiting for test results to come back, all of these things are going to significantly restrict your capacity. So yes, Liz, what I think people will be doing is they will be looking to see, does it make sense to have particular hospitals as particular hubs for treatment, particularly specialised treatment? And we know, for example, there's a debate going on about that in London. But again, it's just within this context of how constrained things are. Saffron, did you want to add something to that?
Yeah, I think we do know that the plans, all trusts of every type and all providers of every type are drawing up plans now to work out how they reduce that backlog and how they make the most of the resources available. And I think one of the things that's been significant about the coronavirus outbreak has been the really quick incorporation of the independent sector into provision to help with capacity. And it's quite clear that going forward, that will be used in different ways in different regions and on different patches to actually tackle the backlog. So I think that that's also an important thing to bear in mind. And what that suggests is that there is regional planning going on, but there's also, local planning and, system level planning coming in as well, so that we can make sure that wherever possible we're making best use of the resource that's available. But I think that the really important thing to remember there, and it's an argument that we often make, but it is very important, is that different places will need different things. So there shouldn't be an automatic shift to a particular way of doing things, say across a region or across a patch, because we know that the Southwest, for example, is much less affected than the West Midlands or London or the Northwest. So, there will be different backlogs to be dealt with in different ways. So I think that we are seeing regional cooperation, we're seeing local cooperation. I think that in some places it probably goes beyond regions as well to look at things like in particular specialties. So there is a lot of cooperation going on because people are acutely aware of the fact that they need to tackle the backlog as quickly as possible.
Kerry, have we lost you?
Sorry, we've got Danielle on behalf of Stephen Morgan MP.
Hi, it's two questions. Firstly, we've had quite a number of communications from both dentists and patients asking, will dentists be allowed to practice non-emergency treatments anytime soon? And secondly, what preparation is being made for winter? So the NHS is already overstretched in the winter months. And obviously now we've got the addition of coronavirus.
So I don't know the precise details about when dental services, non-emergency dental services will come back on stream. But I think from the general perspective, I know that community services that provide dental care, for example, and some acute trusts, I'm sure will be really keen for that to happen, because there must be a rise in the number of emergency dental cases that are now coming forward that could have been prevented, obviously, through routine treatment. So I think that there is a real desire and will for that to happen. But I think that the critical issue here, of course, is both capacity and safety. And how do we practice safe dental care, make sure we've got the right PPE, make sure we've got the right testing, etc., etc. So all of the arguments that pertained to any of the services coming back on stream, we need to think about really carefully. But I was reading something just the other day saying that the number of emergency dental cases coming forward was increasing substantially, and that is very much because we haven't had the non-emergency dental care available because of the fears around safety. I think that on your point about winter and how we're preparing for winter, we're definitely starting to hear those conversations coming to the fore, talking about the post-COVID era now, and awaiting that second surge, as it were. Trusts have been thinking really carefully about what they do, given that they were planning, they would at this point in the year anyway be planning for winter and building in additional capacity. I think there's a real sense amongst trust chief executives that we've spoken to that this is an opportunity. So there is an opportunity in terms of using some of that extra capacity that has been put in place, not necessarily the Nightingale hospitals, but, you know, buying the extra capacity from the independent sector over a longer period as one option. But also the winter is an opportunity also to continue with the really rapid transformations in care that have taken place across the system. So, you know, we know that up and down the country, different parts of the provider sector and other parts of the local public sector have been working together really, really well to provide radically different services to accommodate the surge in demand of coronavirus. And there's a sense that actually winter will be looked at as a means of continuing that different type of care and really testing it out further, as well as obviously making sure that that capacity is in place, because it's absolutely critical that, having avoided the first round of overwhelm that we were so worried about, it's absolutely critical we don't then move into winter, have a second surge of coronavirus and then be overwhelmed. So anything we can do to prevent that and to put the capacity in place is critical. And one of the things I would say we need is some really, really rapid action on social care and all of the associated public health prevention services, because without those, it's really hard to move forward at pace. And at the moment, we've done some rapid transformations, but we've got to find a way of resourcing those and sustaining those over the longer term.
I thought it was particularly interesting that Patrick Vallance, the Chief Scientific Advisor, about a week ago, very clearly laid down a marker about the potential risks of winter. I mean, if you think about how jam-packed hospital accident and emergency departments are, for example, at the winter period, then, you know, trying to run an accident and emergency department with social distancing at the same time in winter feels to me to be like a really, really world-class problem. And, you know, last hospital I visited before lockdown was up in North Norfolk, QEH, Queen Elizabeth Hospital in King's Lynn. And they were just explaining how, because of how badly configured their emergency department was, you actually had people snaking outside the door in a long queue outside the front door. And just trying to make that work, for example, as I said, in an environment of social distancing feels really, really difficult. So our kind of sense is that, quite rightly, you know, this is something that we're going to need to think really, really carefully about. It clearly is going to be a potential pinch point. And again, one of the interesting things I think about COVID is we're still learning so much about it, you know, as it develops. But there is, I think, a pretty clear thesis that respiratory illnesses, viruses of this type, probably do flourish more in colder weather. And the thing that Patrick Vallance was pointing to is also about how difficult it is to potentially distinguish between other forms of respiratory problem that you get in winter and coronavirus. And actually, it's very easy to kind of not misdiagnose, but it's easy to mix the diagnoses up potentially. So again, that was something he was pointing to. So I do think as we kind of begin to start thinking about winter planning, we are going to need to think very carefully about how all of these things fit together.
Thank you. We've got a question that somebody sent in who couldn't join us today, from Lord Balfe. He asks when there will be a sense of urgency applied to restarting services that were postponed, such as cancer treatment and outpatient procedures such as radiotherapy. He said he's been told by a consultant at his local hospital that they're unaware of any plans to restart services.
Yeah, I saw that, Kerry, when it came in, and in a sense, it kind of confirmed the difficulty of the conversation that we've actually got in terms of. I don't think it's quite right to say that there aren't any plans to restart services. The formal position is a letter went out from the Chief Executive and the Chief Operating Officer of NHS England about 2 weeks ago to say, could you please A, restart as many emergency services as possible, and then B, could you please replan to start the full range of services over the next do that planning over the next 6 weeks with an aim to restart them as quickly as possible. So that work is going on. But I thought, as Saffron very eloquently said at the beginning of this call, the real problem is that we are not going to be able to get that full range of services going as quickly, all the range as extensively as we would all like. And I think there's a really difficult issue that we face about how we have the right public conversation about the fact that we are going to need to prioritise. Again, I was very open earlier on about the debates that the NHS is nervous about potentially being sort of having fingers pointed at us. I already feel that trusts are having the fingers pointed at them by certain media outlets, basically saying, hey, come on, you know, people are dying here, or their lives are being, you know, impaired. Why aren't you getting a move on? And I think there's an insufficient understanding of actually what the constraints are. And I think we all have a bit of a responsibility, I think, to be honest and open about those constraints. And I know why governments might be nervous about having that debate, but that is the position that we're in. And I think we need to be open and honest with the public about the fact that it is going to take time. So just again, the other stat I picked up this morning is the Germans are basically saying they're only going to restart their elective surgery 10% in 10% chunks, with a fortnight between each chunk. So in other words, it's going to be 20 weeks before they're back to maximum capacity. And they're also making it clear that maximum capacity is not the capacity that they had before COVID started, because they've got to keep the surge capacity and keep treating COVID patients. But, you know, I just thought that was a clear illustration of, you know, and let's be honest about it, the German system had much more capacity than we did. If you look at its bed base, it's much larger than ours is. So, you know, that's a very clear illustration to me that we have got a really difficult set of challenges here. And I do find it interesting when I talk to our chief execs, what they say to me, and one of them was saying to me exactly this morning, this is going to be the difficult bit, because yes, we moved mountains in the first phase to, you know, to create those 33,000 beds, those 7 Nightingales, but there was a clarity of purpose around a single objective, which in a sense made it dead easy. What they're saying to us is the complexity of managing all of this. So the other regional director that I was speaking to this morning was basically saying he thinks that this, he said he's in the middle of doing this planning job to restart. And these were his exact words. That planning job is the most difficult thing I have done in my career, he said, because there are so many variables that are beyond our control. And it's like kind of trying to play with the Rubik's Cube, because you just simply don't know how this is going to work.
Just to add a point on that, I think that in terms of restarting services, that is another really variable element in terms of, I know, for example, you know, on my local patch, I know that radiotherapy barely stopped during the whole of the coronavirus because of the configuration of the estate, which meant that it was entirely separate, and radiotherapy could take place. They could make it a clean site, and there were no challenges or issues with that, apart from, you know, obviously protecting individuals who were vulnerable, but they felt able to do that. Obviously in other places where the estate is configured differently, that won't be able to happen. So in some places it hasn't stopped, and in other places it may not be starting anytime soon, but that's to do with our estate and what we are contending with there, rather than a decision not to restart services.
Thank you. We've got a question from Lord Bridges.
Thanks very much. Hello, can you hear me, Chris?
Yes, we can. Nice to hear from you, George.
No, very, very nice. And thank you very much for organising this exceptionally useful event. A very simple question on track and trace. Chris, can you just outline what role you think trusts will have in this system? What needs to be done to make it operational, and when you think we will have an effective system up and running, given where we are now?
Well, thank you, George. I should say that George and I a very long time ago used to work together. So it's a long time since we basically said hello. So hello, George. So George, I don't know whether you were listening to the interview I gave to BBC Breakfast this morning, but that was exactly my point, is that in order to make this work effectively, the NHS, which is the natural first point of call for many patients, 111 pharmacy GPs, to a certain extent some of our trusts as well, they need to know what their role in this test and trace operation is going to be. And what's happening at the moment is, for all reasons we understand, is there's an app being built over here. There's a workforce that's being built over here that's primarily being run through a contact centre that is run by a commercial company. We've then got the local kind of trace operations, which are liaising with the local directors of public health. But the bit that our guys are saying to us, all the bits of the NHS, is they don't know what their role is. And their argument is that if you want us to, ensure that we're directing customers in the right way, if you want to ensure that the information that's coming out of test and trace is flowing into our GP records, for example, then we need to know what our role is. And our kind of sense is that because, to be frank, we're quite a long way behind where we should be, that all this is taking time. This is not something I would necessarily massively say in a hugely public environment, but I have to say I'm deeply skeptical about whether we are going to be able to get all of this up and running by the 1st of June, given how far behind we are. Yes, elements of it have been, are going, like, for example, we are recruiting large numbers of kind of contact tracers, and, announcements can be made or information given about 21,000 of them. But in terms of having a seamless and coordinated whole that works really effectively and crucially puts the kind of new additional, often private sector resource and links it up to the core mainstream NHS, that's absolutely kind of crucial. And I think it's quite a long way from where it needs to be. And George, I would just make the observation that one of the real problems with the testing program, the testing regime generally, and we did I thought quite a good briefing on this about 3 weeks ago, if you'll get it on our website, is that part of the problem has been here that when you're creating new things like private sector testing capacity, it's got to link effectively into the mainstream NHS. And one of the things that our members are constantly complaining about is that those who have to rely on that external capacity just find that the links between that capacity and them are nowhere near as good as they should be. So yes, to grow the capacity, you may have to use external sources, but you've got to, interlock it with the NHS. So your third kind of bit of the question was, when do we think all of this is up and running? I'm not close enough to kind of know the answer, but if you sort of said, well, what's your best guess? I thought it was very interesting that ministers were background briefing yesterday, and the government was background briefing that at some point in June. And my view is kind of towards probably the end of June. But in the meantime, it feels to me the really crucial bit is that we then ensure that we're very careful about how you start unlocking lockdown, because if you haven't got that infrastructure in place, and this is the argument our friends at the Confederation were making this morning, is that if you haven't got that infrastructure in place, and you turn the tap too quickly and to ease lockdown, then you really do risk, a second spike. And again, we thought it was interesting that what some of the Europeans were saying yesterday, it's not a question of if there's going to be a second spike, it's a question of when it's going to be and how big it's going to be. And just one final point on the lockdown bit is our word picture for lockdown is of a rather inadequate tap, where effectively you would want to have a very precise tap where you could very carefully turn it on and have a very measured bit of extra kind of, lockdown easing come out, and then be certain about the impact that would have. And then if you were worried about the water flowing too fast, to very quickly turn the tap off. But our argument is that lockdown easing, because it depends on public behaviour and perceptions and quality of messaging, we think it's a very faulty tap. And you might think you're just doing a tiny twist, and actually what happens is it turns out to be a much bigger twist. And then when you try and quickly turn it back off again, what you find actually is that you can't turn it off quickly because it just doesn't work like that. So it feels to us that there is a particular issue around being certain about all of this. and having that infrastructure in place before you start trying to play too much with an imperfect lockdown tap, if I haven't completely stretched the word picture to breaking point. Yeah, Saffron thinks I clearly have, judging by her grimace.
Okay, we've got a question from Munira Wilson MP.
Hi there, thanks for organising this. I'm sorry, I joined a few minutes late, so you may have covered this right at the start. I've got a couple of questions, the first of which is pretty basic. We're not hearing as much anymore, certainly from the acute side, about lack of PPE or lack of access to testing. To a large extent, do you think this is fixed now on that side of things? I think PPE is still quite a concern on the social care side. But what are your members saying on the, in terms of hospital trusts and so on? And my other question was around the digital agenda. Every call I've been on in the last few weeks, either with local NHS providers or with national bodies such as yourself, everybody's talking about the massive and urgent shift that's obviously been made to digital medicine, which had been something that NHS, we all know, had been trying to do for many years, and as somebody who briefly worked for NHS Digital, found it exceptionally frustrating at the glacial pace. And there seems to be a lot of desire that this should stay. Realistically, do you think that's actually going to end up happening? And what do your members need in terms of any additional support, policy-wise, from government or whatever, to make that happen, or just do you think it's just there now and it'll stay?
Shall I come in on this one, Chris?
Yeah.
Okay. Yeah. So I think on PPE, I think you're absolutely right, Munira, that some of this has quietened down, but I think it's fair to say that this still is an issue, and I think we've got a long way to go on PPE. We've got a long journey to travel, and we've got to make sure we've got the right supplies with us, because really returning to something close to business as normal in the NHS, but in a new environment, is going to require substantial and significant levels of PPE, at the same time as we need to be prepared for any kind of further waves of coronavirus that might hit us. So we are in a challenging position there. I don't want to overstate that, and I don't want to understate it either. I think that things have got better. The distribution system has improved. We've seen all sorts of, the kind of local industries that have been set up in order to help with the slightly easier bits of PPE, such as scrubs and visors and things like that, where hospital trusts and others are being significantly helped out. But we also know that there are real challenges. So we know that gowns are a challenge and remain a challenge, and so if you want to return to surgery on a larger scale than we currently are doing, which is probably emergency and a few other bits and pieces, you need that supply of high grade surgery level gowns, and we don't currently have a sustained supply. And I think that that's the bit we need to be really careful about. It is improving, but we need the sustained supply. I think on the issue of digital, that's a point really well made. I think we have seen a massive and substantial expansion of digital capacity across the NHS. I mean, I think one thing was to introduce a license for Microsoft Teams in one fell swoop across the whole of the NHS. That's, in itself, I think has been transformatory from what I've seen from the various NHS trust leaders that are on our WhatsApp chat. They are telling us how important that is, and it really does matter. But in more far-reaching terms, I think we're seeing this across the board. So we've seen really dramatic changes actually in outpatient operations and how that's working. So, not needing to bring everyone in for their outpatient appointment. And I think that has considerably freed up clinician time and administrative time, making that work so that it is much more efficient and productive and better actually for patients and clinicians. And those patients that need to be seen face to face are being seen face to face, but probably that's a slightly easier process than it was. I think, you know, that's also an issue for primary care, where we know that the transformation in GP services using digital, but also the nudge effect of not always needing to see your GP face to face, which means that it's actually people are moving to messaging and phone calls much more readily now. So I think it's caused a change in behaviour. Can we sustain that? I hope so. I think that what we need to see is that really rapid shift capitalised on by everybody. So not just NHSX working with the sector, but the digital first approach being adopted across every part of the system and in all structures in order to capitalise on that. But my sense is that in those places where it's been a real boon, even in really challenging times, people won't want to move back. So therefore, if the experience is good for patients and the experience is good for clinicians and the experience is good for managers, then it's going to stick.
Thank you. We've now got a question from Lord Lansley.
Yeah, hi. Hang on. Keep pressing.
Keep going, Andrew.
Yep. Hi, Chris. Thank you very much, Chris Saffron. Saffron, you mentioned earlier about the those returning to the service and those volunteering and so on. Absolutely fantastic what they've been doing. I'm sure they're under no illusions that this is going to be a very short run thing. It's going to be a bit of a long haul through to next year at least, and are probably gearing themselves up for that. But in practice, is there anything we need to do by way of the regulatory environment to enable that to be achieved? And in terms of deploying them, I think rather than mainstreaming them, is it desirable that they should be, as it were, collectively badged, as it were, as the NHS Volunteer Reserve, something that is visibly a surge capacity that can be deployed where it is most needed?
Do you want?
Yes, Saffron, why don't you go?
So I will go on this. I think that you asked some interesting questions around the regulatory environment. I think we need to think really carefully about that. So I think that we know that, I mean, I think it's around 15 to 20,000 individuals who have put themselves forward to come back into practice across kind of medical and nursing practice, which is hugely welcome. I think that the big issues that arise there are whether they actually take on direct frontline roles or whether they take on more supporting roles across the system. And I think that we have seen, you know, we've seen this one-off change to the professional regulation so that they can return. I think that there are questions that need to be teased out in terms of whether we would make, whether the system, the sector, the NHS as a whole would make that a long-term sustained change to the professional regulation of doctors and nurses, for example. So I think that's something we need to think really carefully about. There are obviously pros and cons to that, but we've got to think about the additional needs of the system versus the additional, and I want to say burden in inverted commas, but the additional pressures that might come with it in terms of training, reintegration, reorientation, and things like that. But I think what we have seen is a really significant boon in terms of those staff returning to practice being able to support, not on the front line, but in other roles. And they've been able to take real pressure off frontline staff and add capacity where it's needed. So we know that clinically trained staff adding capacity in 111 where it's really needed at a highly pressurised time and where more specialised input is needed has been really, really helpful. Or additional support in a behind the scenes clinical role rather than a frontline clinical role also, because one of the issues is the risk factors around this, because we know that lots of the staff returning are older staff, and we know that older staff are more vulnerable to coronavirus than younger staff, for example. So, you know, there are all sorts of challenges around that. In terms of the volunteer deployment point. I think that's a really interesting one. I suppose the notion of voluntary reservists is quite interesting, but I think I wouldn't want to see that in lieu of actually having a really effective, robust workforce expanded in the way that we need to see it expanded, because I think there are potential dangers in going down that route. That's probably more of a personal view than an NHS provider's view.
Andrew, can I just point you towards one thing, which is that in terms of the regulatory structure, as we understand it, the GMC's ability to temporarily register those doctors is dependent upon the Coronavirus Emergency Powers Act, whereas we understand the NMC's ability to register nurses isn't. So there is a question that, on the assumption government will want to demonstrate that all is getting well and they'll want to get rid of the Emergency Powers Act, we just need to be careful that in doing so, we don't remove the ability of the GMC to keep doctors on the register, because our assumption will be there's an opportunity for the NHS here to not just keep those doctors on the register to deal with the immediate COVID crisis, but on the assumption we're going to need to do a whole bunch of backlog clearance, we might want to keep them for 3 or 4 years, and therefore actually if we got rid of the power to do that because we removed it in the Emergency Powers Act repeal, there's a bit of a problem there. And I get the point about the Emergency Powers Act having a sunset clause and people are nervous about the powers it gives. Yeah, get that completely. But if it means we lose that power, that really would be unhelpful. So could we ask you, since you raised the question, to just keep an eye on that, and we'll obviously brief you and others as well, but that's something we feel needs to be kept an eye on.
Thank you. I think we've got time for one last question from Baroness Thornton.
Who I think remains on mute, Glenys.
There we go.
Yeah, can you hear me?
Yes, we can, Glenys.
Okay. My question really is about testing and tracing. I have now twice asked the Minister in the House of Lords about how this will work. And it kind of, because I think we all need to really understand what will happen when somebody tests positive, where does that information go, who deals with it, who's going to do the testing, who's going to do the tracing, and what will their instructions be, and how all those different bits fit into each other. And I'm sort of even more alarmed when I heard your answer, which seems to suggest that you're not absolutely sure how the trust will fit into this. So I'm not really asking you to answer that question. I'm just sharing it, really, in a way.
No, well, I think if you were to ask us again, without necessarily, we might not want to put this into the public domain ourselves, because we're trying to be supportive of our colleagues who are trying to create one NHS and one government response. But our sense is that the reason why I suspect you haven't got the answer is because people don't know at this point. And it was really the point I was making, is that without, again, wishing to be too finger pointy, our kind of sense was that the testing strategy up until 30th of April was completely geared around hitting that 100,000 tests by April the 30th. And for reasons I understand, there was a real focus on that. I think the argument that some of us would advance was that actually alongside that, it would have been helpful if we were starting to think carefully about test, track and trace, or test and trace, however you want to describe it. And our kind of sense is that because there was such an overwhelming focus to hit that 100,000 target, that's where all the effort was being put. So we are now able, hopefully, to turn our attention to the rest of the strategy, or indeed the strategy itself, and work on that, as long as we don't get distracted by pretending it's about 200,000 tests by the end of May. But our sense is this is what is being worked on at the moment. There are kind of pilots to happen, but it's still being worked out, which is why I do think we were a bit sort of legitimate to say earlier that we would be surprised if this was fully up and running by the 1st of June. We may have done our colleagues a great disservice, but actually that's our sense. The one thing I would, to strike a note of optimism as we reach the end, is that we do think the appointment of Baroness Hart regarding to actually run that test and trace and the rider testing regime is absolutely spot on. The reason being is that actually it's really about complex logistics and operations, and she's got a very good background in that field, having worked for the big supermarkets. She also understands the needs of the NHS front line. So we thought it was a very good and welcome appointment, and certainly we have a fairly regular dialogue with her. Our sense is that actually progress is being made, but the problem is that, to be frank, we probably ought to have started to be doing this 6-8 weeks ago, as opposed to perhaps having a sole focus, which is what we're told happened, on hitting the 100,000 by 30th of April.
Great. Well, thank you everyone for joining us. For those questions, we've run out of time. So for those questions we didn't manage to get back to, we'll come back to you over email. And I just want to say again, thank you for joining us for this webinar.
Yeah. Thank you all.
Thank you very much.